All right, I think we may have sufficient participants so we can get going. So today, this is a webinar from the special interest group from ISBNPA, Socio-Economic Inequalities, that I am organizing the webinars and I'm co-chair for. So this special interest group has quite a few activities, and you're very welcome to join this group if you're interested. So just get in touch with us. We have a webpage and you can email us. But today I am really excited to welcome Professor Jean Adams and Dr. Kate Garrott from the MRC Epidemiology unit at the University of Cambridge. And they're going to talk to us about the DEPT tool that they developed. And the DEPT tool looks at explaining differential socioeconomic effects in population health interventions. So welcome to our webinar today, and I'll hand over to Jean and Kate.
Hello, everyone. As Lene said, thank you all very much for joining us at all our odd hours of the day for you all, I'm sure. So I'm just gonna, I was going to introduce Jean and myself, but that's been done. So the project we're going to talk to you about today is how population health interventions to promote healthier diets and increase physical activity, and explore how the demands that they place on individual agency may influence intervention effectiveness and equity. I'm not going to go into detail today about why tackling poor dietary intakes and physical inactivity is important, because I think everyone in this room knows that. But this project has been based on diet and physical activity interventions, and we think that it could be applied more broadly to other health behaviours too. So before I carry on to talk about this in more detail, I just want to thank the NIHR Public Health Policy Research Unit for funding the work, and for our collaborators at the University of York and London School of Hygiene and Tropical Medicine, as well as the rest of the team at Cambridge. So this work is based on population health interventions. So those are interventions delivered to whole populations or groups of populations defined by non-health characteristics. And many of these are implemented globally, often implemented by national or local governments, demonstrating that we are taking action to address obesity rates, but that's no surprise. And in this room, we also know that inequalities in achieving healthy diets and adequate physical activity exist, and that narrowing these inequalities is a key priority. And so, therefore, it's really important that we understand how population health interventions implemented to address obesity or dietary inadequacy and physical inactivity, how these interventions might influence health inequalities. So in 2016, Jean and the team published a paper exploring why some interventions are more equitable or effective than others, focusing on the role of individual agency. So for those of you who may not be familiar, I'm selecting these two types of interventions as extremes to help illustrate and introduce the concept that's going to be the focus of today's seminar. So this is a health promotion campaign. I'm using it a little bit tongue-in-cheek, but it was from Health Education Scotland in the mid-1990s. Now, if you think about what someone has to do between seeing this poster and making a positive change to what they eat, it places a lot of demands on the individual. So first off, they need to read and understand the message. Then they need to operationalize the message, which might be easier said than done. They need to have the opportunity to enact the message, and then they need to do so. Now, these types of interventions rely on individuals living within environments that provide opportunities to enact such messages, but then they also rely on individuals to do most of the work. They need individuals to encourage or to mobilize their own resources. In this case, it might be time, financial resources, or cognitive resources. But what we know is that these resources aren't distributed equally across society, and people living in more vulnerable circumstances have less financial resource, may have less headspace for dealing with new problems, and may have less access to environments that support such behaviours. And therefore meaning that These resource constraints mean that they're less able to respond to this type of intervention as intended. On the flip side, individuals with more resource are those that are more capable of responding to these types of interventions. Therefore, they may exacerbate inequalities. In contrast, interventions such as tap water fluoridation or fortification of flour with folic acid as examples, they change the environment to support diet and physical activity and require action from water companies or food manufacturers. But no behaviour change or no demand is required of individuals, and they increase their fluoride intake by continuing to drink the tap water or continuing to eat products that contain the fortified flour. So you may have heard the terms high agency or low agency interventions used to describe this idea, which has led us to use the term agentic demands, the demands on individual agency. But whether we talk about individuals, agency, resources, or agentic demand, it all really amounts to the same thing, that some interventions require individuals to do a lot of work themselves, and those that do may be less equitable. So despite growing traction in recent years, the supporting evidence base to underpin this theory is quite limited. And a key barrier to generating this evidence base is that there's not a clear method to determine how we classify interventions according to this concept. So this figure from the 2016 paper I mentioned earlier illustrates that the concept of intervention demand on individual agency lies on a continuum from low agency here to high agency here. So while it might seem that that's intuitive, and these extremes that I have explained fit neatly into the low and the high agency, in between these, there's such a broad range of health interventions or population health interventions that classifying these into a two-category system masks considerable complexity. So that you can see examples of road user charging, calorie labels on menus, monetary vouchers for fruit and vegetables, for welfare recipients, advertising restrictions, or new cycle lanes. That if we were to try and categorize these into these two high or low agency categories, doing that consistently between researchers and users is, well, I think nearly impossible. But why does this matter? So firstly, without a way to classify, we can't develop an evidence base to underpin any policy decisions about interventions that might influence intervention equity. But also, once we understand this, the intervention characteristics that contribute to the agentic demands of interventions, we may be able to design policies and interventions that can maximize effectiveness and equity. So this project really aimed to develop a tool that we can use to classify the agentic demands of population health, to do justice to the complexity of the different types of interventions that we commonly may use. So the methods for developing the framework were iterative, as you can see from this diagram. So we moved backwards and forwards through each of these main stages. Given the time, I'm not going to go through these in detail, but just very briefly kind of explain how we did it. So the first stage was that we identified examples of population health interventions by systematically searching databases for systematic reviews excuse me, on dietary and physical activity interventions. From these, we extracted the population health interventions and screened them using kind of the table of study characteristics. And then for all the included studies, we identified the linked papers. So we searched Google Scholar for the first and last authors, and I tried to identify process evaluations, qualitative evaluations, protocol papers, anything that gave us kind of more information about the interventions themselves. And for each intervention, we then used these articles to code out who was involved in the intervention, so the intervention actors, and what each of these were required to do. So that we came up with, for each single intervention, a list of what had to happen for the intervention to have its benefit for the intended recipient. And after we had this for each individual intervention, we grouped together similar intervention types, for example, provision of information or increasing availability of food, and amalgamated these into similar intervention schematics, which we then compared and contrasted in order to develop a draft of the framework. Now, the initial draft, it's changed quite a bit since the initial draft, but we sought feedback from academic experts who gave us qualitative feedback via workshops after attempting to apply the framework. And based on this feedback, we refined the framework, and then we did some reliability testing, asking groups of academic and policymakers to apply the framework to intervention examples, and we compared their responses using integrated reliability statistics. So we've termed the final framework the depth tool, or the depth framework, which is the demands of population health interventions. And I'm going to take you and explain how we develop, how the framework, is constructed, and then how we applied this. So the three constructs that we identified that influence agentic demand are exposure. So how do intervention recipients first come into contact with the intervention? So, for example, visiting a restaurant, people can come into contact with calorie labels on menus. The second is the mechanism of action. So how's the intervention proposed to work? For example, one way that menu labels might work is by providing information to the customers. And lastly, is engagement. So how are recipients or individuals required to respond to the intervention? So, for example, in order to benefit from the calorie labels, restaurant users have to use the information provided in order to make their choice from the menu. Now, these three constructs are assembled into a matrix that classify interventions into similar categories, which I will show you how this works now. So the first concept of exposure, which is how the recipient group first comes into contact with the intervention, can be classified as active. So where individuals have to make a change to their existing activities or locations in order to come into contact with the intervention. Or it can be passive, where they come across the intervention as part of their normal routine activities. And I'm going to show you now how these form a matrix using examples of interventions from the WHO's Best By interventions for non-communicable diseases. So mass media campaigns distributed either via websites or via digital apps require individuals to either download new apps onto their smartphones or visit websites that they might not commonly visit. And so both are examples of an active exposure where they've initiated a new activity to come into contact with the intervention. But we have a wealth of examples of these passive exposures whereby individuals can be exposed to nutrition labels on the front of packets when they're visiting the supermarkets. When they are attending school, they may be exposed to lower sodium options in the school canteen. There may be product reformulation of commonly used products to reduce sodium content, and so people would come across that as part of their daily food consumption. Raising taxes on SSB, so sugar sweetened beverages, when people go and purchase them, or physical activity counselling as part of routine healthcare appointments. And these examples really illustrate the difference between active and passive exposure. So the second concept in the framework is the mechanism of action and how the intervention components aim to enable the intended behaviour or discourage an alternative behaviour. And we classified these into 5 main categories displayed here, that I'm not going to read out the definition of each single one, but I think that detail is in the paper, but there's just an illustration here of the 5 categories. So adding in the mechanism of action into the matrix begins to take shape. So using the same examples, we can see that the mass media campaigns, the front of pack labelling, the physical activity counselling are classified into the cognitive mechanism because they aim to change an individual's knowledge, skills, or beliefs or values. But then we can see that this maintains that distinction between the active and the passive exposure. The taxes on sugar-sweetened beverages, they operate by financial mechanisms as they change the monetary cost of and increase the cost of purchasing sugar-sweetened beverages. And lastly, bread reformulation and the provision of lower sodium options in schools fall in the physical environmental category because they change the properties or the placement of objects in the environment. So as I've been going through that, you might think that some of them have multiple different mechanisms of how they might work. So for example, mass media campaigns, as well as operating via a cognitive mechanism, may aim to change sociocultural norms, so may fall into 2 different mechanisms. And we can handle this in the depth framework by allowing users to classify multiple mechanisms for each intervention component. So instead of just having to choose a cognitive resource, we can assign menu labeling to both sociocultural and a cognitive mechanism. That might apply to lots of the different intervention examples that I've used, but I'm just, I guess, illustrating at this point. And there's also approaches like this to account for the fact that interventions often have multiple components and different recipient groups as well. So the final concept in the depth framework is engagement. So this is the degree to which recipients are required to be aware of or interact with a mechanism of action in order to benefit. And once again, this can be active. So individuals are required to purposefully interact with the intervention. Or passive, where they don't need to interact with the intervention once they've been exposed to it. And adding this into the matrix brings us to the final 20 category classification. And now we can see how the examples that we've used can be differentiated by their engagement requirements. Many of the ones in the WHO recommendations do use active engagements. That's why it's quite heavy here. But we have that recipients are required to purposefully interact with mass media campaigns, front of pack labelling, the physical activity counselling, the sugar sweetened beverage taxes, and changes to the options provided in schools. Once individuals have come across these, they still have to make a choice or take some action in order to benefit from these. And this is different to the passive exposure, where individuals don't necessarily have to be aware that a product has been reformulated in order to benefit from this. Of course, some of these again, it depends how the intervention is operationalized and described, because it may be that lower sodium options provided in schools might operate via sort of nudge strategies, which are strategically aimed to minimize, I guess, the conscious engagement. So they might be passive, but it all depends how the intervention is implemented. So here is the final version of the framework that we have populated with intervention examples, so that you can see, I guess, the breadth of intervention types that fit within this tool. And like I said in the introduction, we've developed this tool for diet and physical activity. But when I was going through the WHO best buys and selecting out the interventions to use for the seminar today, they had a host of other behaviours that I just wanted to illustrate that they may be able to fit into this framework. So there may be bans or restrictions on alcohol advertising that would fit down in this category, or the provision of drug therapy for eligible people at risk of cardiovascular disease. So it's likely to fit other health behaviours, but we do need to test this more systematically. So I guess that's the introduction to outlining the framework. But the outstanding question really is, so what? This on its own doesn't really help or tell us anything about how interventions influence are effective or influence equity effects. So our last stage of this project was to explore whether the categorization was associated with intervention effectiveness and equity, to begin developing the evidence base to support selection of interventions. So we adopted a proof of concept systematic review to explore, firstly, I guess, whether it was possible for us to implement this framework in a systematic review. So we took 3 existing systematic reviews exploring the equity effects of dietary and physical activity interventions. And from these, we extracted 31 studies to be included in this review. And for each intervention, we extracted data on depth framework classification for each intervention component. And we extracted information about intervention effectiveness and their equity effects, which I'll explain a bit more about in the next slide. We then plotted the depth classification and the equity effects on harvest plots to visually display the results, which I'm going to present now. So the outline of the harvest plots are very similar to the matrix. You can see that we have the exposure here and the engagement and the mechanisms of action along the top. And the overall matrix includes 1 cell for each classification. Each cell is broken into 3 columns, according, firstly, in this harvest plot, to the intervention effectiveness. So we have results that favoured the intervention group, results where there was no difference between the intervention and the control group, and results that favoured the control group. And in each cell, we've included a bar. I've illustrated a few bars here, where the height represents the number of intervention components in this cell that support the hypothesis. So in this example, there are 11 interventions where the results favour the intervention group. And the black bars represent dietary interventions, and the grey bars represent physical activity interventions. So this is the final matrix with the results for intervention effectiveness. And we can see that for the dietary interventions, they favour the intervention groups in most of the categories, apart from these 2. But I don't think we can take very much from this because there's so few interventions included here. But the findings of physical activity, I think, are more mixed here. There is some indication for both dietary and physical activity interventions that they were more consistently effective when the exposure was passive rather than active. So those interventions where individuals come across them as part of their normal daily activities. But the evidence, I think, that I presented here for intervention effectiveness is less, I guess, robust, because we've taken these studies from reviews on intervention equity, so that we need to bear that in mind interpreting these. There's a similar approach here with the harvest plots on intervention equity, using the same matrix where the 3 columns show the effect on socioeconomic inequalities. So we have here likely to reduce socioeconomic inequalities, no gradient, or likely to widen inequalities. And it's the same principles for the bars as the effectiveness in the previous graph. So the height represents the number of intervention components, and the dietary bars are black and the physical activity bars are grey. So here's our results again. And so I'm going to highlight what I think are the key findings from this. So highlighted first is the column where about interventions that are likely to reduce inequalities. And I think what we can see here is that there's very few interventions that we found in these reviews that fall within these categories. The next thing to highlight is that there does appear to be a pattern that some interventions operating via cognitive mechanisms, so provision of information or improving skills, may appear to widen inequalities. And the balance of this seems to change according to whether the exposure is active at the top or passive at the bottom, suggesting that these are important concepts to consider. And the final point I think really to highlight here is that there's a paucity of interventions within certain classifications. And we've managed to come up with examples of interventions that might fit here. So it's not that they don't exist. It might be that we haven't thought of them yet or we haven't tested them yet. So it presents quite a novel and exciting opportunity for potential intervention development. So I'm gonna start to, I guess, sum up what I've presented, and I guess the first thing is that we have we've identified three constructs that influence the agentic demands of interventions. The results of applying this have found that interventions that operate via cognitive mechanisms may be more likely to widen inequalities. We really found very little evidence of intervention approaches that do reduce inequalities, but found gaps in evidence on some classifications. And I guess our potential practical implications is that this has potential to be used in evidence synthesis, but also in the selection and the design of interventions or in intervention evaluation. So I'm just going to finish with some, I guess, final thoughts on the strengths, on limitations. And the conclusions of this work are really based on a proof of concept review. And so future work should really try and build on this to answer this question in a more definitive way. As I've mentioned, we've developed this based on dietary and physical activity interventions, and it might be applicable to more to other health behaviours, but this needs to be explored. But I think it's quite clear in the results that I've presented that we're really reflecting a bias whereby interventions in certain categories may be more feasible to implement and evaluate, and so there is kind of more evidence in some of the categories. And I think all the studies we were looking at, or when we were attempting to do the review on intervention equity, it was notable that there was a limited amount of data with which we could do this research. So I'm just gonna put a shameless plug here for the paper that was published maybe about a month ago. And we are in the process of finalising a digital application tool in order to apply this tool to interventions for using in a systematic review. And so I would like to thank all of the project team and the funders, and I think Jean and I will now join you for any questions.
Thank you very much, Kate and Jean. Really brilliant work. Great to hear you present it. So now we have time for questions. So you can type your questions into the Q&A. But while we wait for questions, I have a few. So maybe I'll kick you off with one. So you briefly mentioned that this framework can also be used for intervention design. So how do I best apply your framework for the next intervention I am designing?
So I'll start. I guess with intervention design, we're not thinking about it in terms of right from the very start. It might be about thinking about how you tweak interventions that you are about to implement. So, for example, we recently did an evaluation of financial incentives to promote alternatives to the car. And one of the kind of control group, or the usual practice, was that people had to claim them via websites. And we ran an intervention group where, as well as increasing the value of the incentives, we sent the incentives directly to participants via email. So we kind of changed the exposure of that particular intervention. So it might be used in that way. Or also at the very beginning, when you have a kind of different selection of interventions, or a range of interventions that you might be able to choose from, it might be at that point that it's useful to consider how they fit into this framework to help you select them.
Thank you. Then I suppose I'll just keep going with my questions, because I have so many after your great presentation. The other question I had is, do you think in general we should aim to create interventions with low agency, or is there ever a place for the ones that have higher agency?
Okay, do you want to take this one?
Yeah, I think that sometimes this work has been misconstrued as suggesting that like one group of interventions good, another bad, and I don't think that at all is ever but what we've been wanted to communicate. I think more maybe that there's a kind of a bias in the literature in how we propose work and how work is funded for various reasons on interventions that have place quite high demands on individuals and have high agentic demands. You know, they can be considered more politically acceptable. They're easier for researchers to design and deliver themselves. Like, can't go about implementing a soda tax from my office in Cambridge. And so all those things that are not really our fault, but just kind of shape how we do research, means that there's, like, as Kate showed, there's a big chunk of interventions that we're just not really paying attention to. And by giving them a name and starting to try and define them, we're hoping that that helps us as a community to expand a little bit. I think the other thing is that, like, that's a really interesting question, and how might you use this as divine interventions? And Kate gave some really good examples. The other thing that we've talked about is, if, I don't know, for some reason, like food labeling is just a thing that we're going to do today, right? That's the intervention that's going to happen. You could, it's feasible, and this is kind of a hypothesis, but that might work better for more people if you combine it with something that has more passive engagement required. So food labeling alongside something else. Yeah, and I guess that kind of responds to both of your questions of how do we design interventions, but also how do we kind of think about the sorts of interventions that we should be encouraging governments to be supportive of.
Right. Yeah, I like that idea of thinking about, when we have an active cognitive intervention, to also think about something passive to make it easier. So maybe even combining some of the domains in your, and I suppose just as a thinking aid to make us think about what kind of demands do our interventions place. Thank you. That's great answers. I suppose the other question I had was around, it's really sad, and I think that's something, unfortunately, we've seen previously in the literature, that we have health equity problems. We design interventions to reduce inequity, and in the end, we often widen the gap while we don't really do a thing. So I'd love to hear a little bit more about your thoughts on that. Why do such few interventions reduce inequalities? And again, what can we do as a research community to get better at that?
I think we have very little evidence on what narrows inequalities, possibly because we haven't explored it very much. So, like Kate presented, all the work we could find from systematic reviews on reducing inequalities in diet and physical activity, and it wasn't loads. So we just don't look at equity effects very much. And it's feasible that when we do it, we're also biased to which particular interventions we're looking at. And so we look at those that have been under researcher control, just like described in the findings, that the kind of cognitive mechanism interventions are the ones where we have the most data. So I suspect that this is a bias of how we do research, rather than we don't necessarily know what narrows inequalities. It might, or rather than there aren't interventions that narrow inequalities, I suspect part of the answer to that might be that we just haven't studied them very well.
Right. So maybe a shout out to everyone listening here to think more about inequalities when you're conducting your research, how you measure it, how you may reduce it, and hopefully we can fill your slides with some more examples of where it works in the future. Great, thank you very much. I'll just keep asking questions because I have so many after that great presentation. But just to anyone else who's listening, if you do want to also add to the questions, you do still have the opportunity to post in the Q&A. So the next question I had was around, so you mainly talked about physical activity and diets. Have you also been looking at your framework in other health areas? And does it directly apply to others? Is it a general framework, or is it more for these two areas?
So we did develop it based on using interventions solely from dietary interventions and physical activity interventions. But I think what we sort of noticed as we were developing it was that lots of the interventions proposed for other health behaviours are quite similar and likely would fit across the framework. Just to keep it manageable, because we couldn't review everything. We did decide to just keep it to diet and physical activity, but I do think I think in the course of developing it, in the course of thinking about other interventions, as I've been developing it, there's definitely spaces where this overlaps with other health behaviours. And I think it could be used, but I think anybody who does use it probably just needs to do a little bit of testing, I guess, and seeing how it does fit across other health behaviours.
Right. It's really interesting. I suppose my last question for you then would be, what's next? So what are you working on now? What do you think are the next big things to do in this area?
Go ahead, Kate.
Oh, so I was going to say, so we would really like to do a full systematic review based on the same questions and just spend a little bit more time rather than the proof of concept approach that we took at the end of the project to see whether we could feasibly apply the framework. So I think it's really indicative of some of what we think we will find, but I always feel like we're kind of just scratching the surface on, I guess, providing a more definitive answer. So I'd really like to be able to do that.
Right, thank you. And we do have a question from the chat. So in the Q&A from Monique Tan, the question is, who do you think would be the best place to use the framework? Sorry, my reading is still a little bit off this morning. Is it mainly meant for academics, or would you target a wider range of users?
So we have thought of like two main user groups are academics in doing reviews, developing interventions, and also policymakers. And that speaks to some of the things we were speaking about how would you use it to develop interventions. And we're thinking that they might use it in terms of prioritization or some of the kind of tweaking strategies and packages of interventions that we talked about before. But we're really interested to see who does use it, how they use it. If you read the paper, you might notice that we've described how we used it rather than the kind of rules for use. And we're really interested to see how other people use it and adapt it to their kind of use cases.
Excellent. Well, thank you so much for developing this great tool for us, or for not just for us, for researchers, policymakers, and so on. I think it's really great work. It was really interesting to hear about it. Thank you for the great presentation. I do believe this webinar is recorded, so if any of you are listening to this and think your colleagues would really benefit from also hearing it, that should be possible soon. Antonio, is that correct?
Lene, yes, it is. Lene, I think we have one question from Monique. I don't know if you have answered.
Yeah, we already read that one out.
I already did.
Yeah.
Okay, yeah. And yes, the webinar should be available, I'm saying, in 24 hours or something on ISBNPA website. Okay.
Excellent. So yes, please do go read the papers. Do spread the word about our webinar, and thank you so much, Kate and Jean. It's been really great hearing you present this morning and answer all the questions we've had. So have a lovely day.
Thank you.
Thank you.